So we don't use a tool like Lee is using at St. Joe's. But I'll tell you kind of what my personal practice is with regards to these cases and how things have changed over time. I think Lee said one thing that I have to agree with, that I think I have the advantage of having had seen thousands and thousands of kids. I spend the majority of my time at Mott, and I also maintain my adult patients and see patients over at University Hospital too. But most of my time is spent with children. So I think that gives us a little different perspective on kids with head injuries, especially those kind of intermediate head injuries. I do use the PCARN rule each and every time I see one of these kids with minor head injuries. I consistently discuss it with my residents. I talk about it with our physician assistants. Just about all of them, with the exception of the newer ones, are very familiar with PCARN and use the PCARN decision rule as well when they are seeing children. So I think when the PCARN rule says, oh, it's less than a 0.5% chance of severe head injury, everyone's very comfortable in not getting a CT scan. It's the young infant that comes in who's had 4 or 5 episodes of vomiting. I think that's where people get a little bit uncomfortable in terms of like, do I scan this child or do I not scan this child? I have to say that over time, my practice has changed in this particular age group and this particular kind of presentation. Whereas maybe 5 years ago, I would scan that child. But now when I go in, I hear the 4 or 5 episodes of vomiting. I see a very happy, well-appearing child sitting in mom's arms who's got a very normal neurologic examination with no outward evidence of head trauma. Now I'm more likely to observe that child. We do have the advantage of being able to observe these children in the emergency department, and we do have a traumatic brain injury protocol in which we can observe children up to 23 hours in the ER if we need to. Most of the time it's just the standard, 4 to 6 hours, and then if they're well appearing, they get discharged home. So I tend to use observation more than I use the CT scan unless I'm highly suspicious or it's a high impact injury or there's something else kind of affecting my decision as to whether or not I'm going to CT the child. Usually I opt for observation, and I rely upon the science behind the PCARN study. So I've been practicing since 2008, like Michelle said, and I'm not aware of any missed cases of severe head injuries after using the PCARN, after applying the PCARN rule. So, I mean, I'm not exactly sure like how I compare how my practice pattern is different compared to my colleagues at Mott, and why my practice pattern is different in comparison to my colleagues. That would be like one question I would have, and maybe that's one way that we could help some others to change their practice. But if I had to guess, I would say it's that kind of intermediate head injury case in which people are uncomfortable. I think there are some people who are more conservative and would tend to lean on the side of conservative and scan the child as opposed to observe, or as opposed to observe. I usually have in my experience, when I talk to the parents about CT or no CT, and if I say no CT, most of the parents are very comfortable with that decision, and they're just looking for reassurance. Is my experience that they're just looking for reassurance that there's nothing severely wrong with their child, and that they need a CT scan. And most parents are also very happy with a period of observation. And I haven't found any parent to say, absolutely not, I don't want to stay. And so because of that, I think I do, the other thing I think about is irradiating a growing child's brain. We're not exactly sure what the impact is on that child. And then in terms of like lifetime exposure to radiation, I think about that a lot. I think about the unknown impact of cancer in these patients. And I think that's one of the things that drives me to really think twice about whether or not I want to expose a child to that type of radiation.
Helena, I have one question for you if on the theme that you just spoke about, and then I'm going to open it up to the group. You know, what do you say to APPs or trainees who come out and see a patient that falls into this group and they're about to or have already ordered a CT scan? What tools do you use if beyond just talking with them, say, wait a minute, you know, let's think about this or whatever? Are there any tools that you use practically in the ED?
I mean, besides reviewing kind of the PCARN data, I think that's the strongest tool that we have with regards to this discussion of whether or not we should scan a child or not scan a child. With my emergency medicine residents, I talk a lot about the differences in practice between kids and adults. I talk a lot about, you know, going back to the use of radiation in children. I talk a lot about applying, you know, making sure that we are doing what's right for the patient when it comes to the emergency medicine residents, because we know that the adult practices are sometimes different than the pediatric practices. And so I do spend a lot of time with my emergency medicine residents talking about the differences between children and adults and why we want to think twice about a CT in a child versus a CT in an adult. But I don't have any specific tools, Michelle.
Okay.
Like what Benjamin, you know, what he's developed for St. Joe's.
And just for context for the group, Michigan Medicine, you know, our PAs are kind of working in the milieu with us. So they're not like in a separate room or a separate section of the ED where we can't see them. They're tending to be all around us. So there is some easy interactions with our APPs. They're maybe a little bit different in other settings where they might be a little bit distant from you. But I wanted to open up the time to ask Helena any questions or just general questions about this with relationship to your site and your performance or any barriers you're experiencing. So let's open it up to the group. You don't have to hold up your hand. You can just start speaking.
I do have one question for you, Dr. Wang-Flores. A lot of the focus that we've been kind of centering in on lately is like the quality improvement work. And I'm just curious if there's anything that's been particularly helpful for you as somebody who's not immersed in, you know, the medic on a daily basis, you know, in keeping you engaged. And like, I don't know if you guys ever receive reports on your performance or anything like that. Is there any education tool, communication, or resource that's been particularly helpful with you in your practice in receiving that?
So I mean, I know this information is available to me if I go and seek it, but in all honesty, I haven't really looked at my own data. And this data, you know, Michelle doesn't, I'm sure she doesn't have the time to look up each individual person's data and send it to us. And so I haven't seen that data.
That's totally fair. I was just wondering if there was anything in particular that's been beneficial.
Not really. I think it's really I think it's really the things I've talked about already. It's, you know, it's my own concern about use of radiation in children. It's applying the PCARN rule judiciously and trusting in that science are the things that drive my behavior.
So there's one other thing that I think, at least I know that I do, and maybe some of the other folks on this call maybe use this too, is I do use MD Calc a lot on the fly. particularly when I get any pushback from trainees or PAs or maybe a new medical student who are seeing a new patient. I feel like, you know, the ED is a fast-paced environment, and oftentimes, you know, I can't, you know, take the time to pull up an article to really review it in detail. But what I can do is quickly go to the MD Calc website, and if anyone on the call should know about this, and if you just type in Google MD Calc PCAR and head injury rule, you suddenly are in this little tool that you just say, my child's under 2, older 2, and do they have this, do they have that? And then boom, there's your risk assessment right there. And really kind of, and then if you want to ask more, goes into more detail as needed right there on the website. So I found that to be a very helpful on the fly tool for people who are a little bit skeptical about, you know, some of the discussion that you're having. And I find that to be very helpful, at least with the providers who are thinking about or you know, are on the verge of ordering a scan when there may be some room for holding off on that.
I agree. I do use the MD Calc tool a lot, and I use that also as a teaching point for the residents. And I show them, I pull it up and I say, see, the patient's risk is this. So we really don't need to CT the child. I also ask the residents, so you can copy and paste that information right into the note, and you can say and put in the note that the patient's risk is this according to the PCAR study.